No, he summarized it perfectly at the end. I got nothing else to add because he said all the check mark statements at the end.
Yes.
Yeah. Hi everyone, welcome back to the Care to Talk podcast. I'm Alina from the Wellbeing Office at the National University Health System, and I'm so glad to have you with us today. Today is our 5th episode of the podcast, and the theme is Every Person Has a Story. And it's really going to be an episode about compassion and resilience. Every person that we meet in life has a story that we might not be aware of. Everyone comes with a history of ambitions, of hopes, of triumphs, of adversity and setbacks, and also growth and resilience. Usually it's unseen. It's something that we don't know immediately upon knowing them, but it does affect how they and we show up and interact with each other. At work, relationships tend to start out very transactional because we're very task-oriented. So we might not take the effort to really get to know who is behind the role that they are playing. And sometimes we fail to even look for that, although it has a lot of implications to how we relate to each other. Today, our guest is Dr. Darryl Tan. He has a very personal story from one of our own staff to hear what they have gone through in the context of health challenges and how he has coped, pivoted, and ultimately found a new path. So, Darryl, welcome to our podcast.
Thank you for having me. I'm a principal resident physician with the Department of Psychiatry in Ng Teng Fong General Hospital. I've been with the department actually since 2014. Over the years, I think apart from clinical work, I started getting involved in supporting our junior doctors, our fellow colleagues in the course of work. Later on, then I took on a little bit of patient safety work, looking after safety culture, psychological safety, human factors in the workplace. And since last year, then I've taken on the role of overseeing patient experience as well as culture within the medical job family.
Okay, that's really interesting, and I think we're going to have to delve a little bit into how you got into all this. So you decided quite early on psychiatry?
The interest developed since medical school. Certainly, I think the posting was a great experience. It was a bit of chance as well, I think, with the rotations we get. So I got assigned to IMH as a very early, I think, first MO rotation.
So you were on your way to becoming, going down that travelator path that we all do.
Yeah.
But then something happened.
Yeah, so I was fresh out of NS, started my first posting, and then towards actually the tail end of the posting, then I found out I was diagnosed with lymphoma. I was, I believe, 28, thereabouts.
Can you share a little bit about how that came about? How did you even know?
A bit complex of a medical process because actually I had a history of autoimmune conditions as well. Really stroke of luck, I also happened to volunteer for a practice MRI brain scan. Right, so I was asymptomatic completely well. I was going about my work as usual, and then suddenly up pops these white patches in the practice brain scan that no one knew what to do with. But it still took 2 weeks before they figured out what was going on, because the brain is not somewhere you can easily sample, right? You can't biopsy so simply, and a lot of the medical reviews were clear. They didn't show anything. Of course, complicated by the fact that I was on steroids, right? Immune suppression for the immune condition. So everything kind of mixed together to create this picture. Fortunately, they found a lymph node eventually, which they were able to sample and then diagnose the lymphoma, which put things at stage 4, stage 4A, 4B, thereabouts. There were some symptoms also emerging, and then that's when treatment started.
Wow, this really was just a kind of came out of nowhere then.
Yes,
because you were feeling
absolutely,
completely well,
yes.
and
Yes.
totally unexpected.
Yes. Actually, lymphoma was not the worst diagnosis that could have been if you can imagine. So the fear at that time was a degenerative
I see.
disease. There were other things that actually don't have treatment. So in that sense, I would really say that diagnosis was kind of a mixed bag, really a mixed bag, in the sense that at least it was something that was treatable, right? Even though it was aggressive. Yeah. So I think there were processes. Yeah, there were definitely a bit of a journey in that.
So Darryl had this special skill set. He had the ability to be cognitive about it, and you had, so at that point, because of your psychiatry training, already more insights into recognizing at least the emotional aspects.
To a degree, I don't know how much of it was that as well, but also I think my early kind of foray or exploration into mindfulness practices, I think that had already started earlier, slightly earlier on, not very seriously, but just understanding that, okay, we do have emotions, they are normal part and parcel of the process, and how do we then cope with things. I did learn about it through work. Some of the early exposure happened through actually my faith, right? And spiritual practices. Rather than just existing very cognitively, very emotionally, we could kind of step back and take a different view of things.
Okay, I'm very glad that you had that at the time, because I think, just looking at the facts on paper, it feels like there was a lot going on, and you were able to calm things down.
On hindsight I guess, speaking about this, a lot of it is hindsight. In the midst of everything, the hustle and bustle of things happen really quickly at that time. I think it was a serious diagnosis. Fortunately, the medical team stepped in quickly, treatment started. So it was really a lot going on, and it was just a matter of, I think, putting a foot in front of the other at that time. There were moments, I remember, the emotions did come up, and then just, managing to deal with it at that time. Yeah.
How did you get support at that time?
Of course, a lot of it was family. And the second thing then, of course, is the faith component of things, the community I had, friends through church and things like that. That was a big, I think, part of things. And thirdly, actually, is the role that healthcare plays and the way we support each other. I think that's one of the really precious things about working in healthcare, especially public healthcare. It's that early idea of being able to look after one another.
So from that lens of having previously been a provider, you were able to see actually and appreciate how much effort went into your care.
Yeah.
Yeah.
And for me, my perspective going in, I think as a healthcare worker, you know how they always say healthcare doctors make either the best patients or the worst patients. So I think from my angle, I was quite determined to be a good patient. So I think that was an early lens of looking at the idea. I know how tight, right, our resources often are on a general ward. Right, and so going in with that idea, okay, are there small things that I can do that are a bit more helpful?
Now, when we look at it, all these years later, we know that that's actually a coping strategy, to take things away from yourself, and perhaps that's kind of unconsciously what you also did.
Interestingly, I didn't really think about it that way, but now that you've put it that way, I guess yes. One emotional aspect that I really struggled with on hindsight and that I remember is the idea that instead of being able to provide care for people, that I was now someone that needed care or was going to be a burden. And that was very acutely felt, especially with my family.
Listening again to the story, I think two things, right? The faith, I think, is something we see in patients also, whatever their background, whether it is faith that is linked to a structured religion or not, that idea that gives them peace, that gives them some understanding, it does seem to bring people a lot of strength, and I'm glad that it did that for you. And the other thing is again, what you mentioned, we see a lot of we hear from a lot of patients, I don't want to be a burden.
Yeah.
And we hear it, and then if we have never experienced it, sometimes we think, no lah, of course, you know, your family won't mind. Of course, they want to be there for you.
Yeah.
But when you are in that
Yeah.
situation, it's knowing that on cognitively on one hand and feeling that you don't want to be that burden are two different things lah.
Yeah, and I think perhaps this ties in a lot with our sense of meaning and purpose, right? And being able to then transition easily between caring for and being cared for. I think these are boundaries that, in general, if we think about well-being, we think about thriving, we need to be able to float between these two states, because there will be times, and all of us, I think, would have experienced times we need a bit more care.
I'm gathering you're a very optimistic and positive person, so perhaps it was more challenging than you make it sound now, but it's good that in recall actually you
Well, the problems came later.
yes, okay,
because,
so we've not gotten to that.
Yeah, the problems came.
Yet.
That's not the end of the story
okay,
yet, because about a year after, actually towards within 6 months, I started developing hip pain.
Had you gone back to work?
Yes, just about when I had started going back to work. Started developing hip pain, which I thought was my autoimmune condition coming back, right? Because the autoimmune arthritis. So I kind of tried to let it settle, which on hindsight I shouldn't have. But eventually it turned out to be avascular necrosis of the femoral hip, and on both sides eventually.
You had just gone back to work.
Yes.
The cancer is
remission.
Remission. And then now you've got this new thing.
New thing, yes.
What did you think?
That was again another upheaval in terms of that. So another really almost a grief process, right? And then, yet another disappointment. So I think, but again, one foot in front of the other. But eventually, I think it was by 2015, I decided, the pain was just too bad.
Can I ask what work was like during that period? So you had taken a year off or 6 months off?
I had taken thereabouts about 10 months.
What was it like to first come back to work after that period, that first period after you had been unwell and then recovered?
Not too difficult. I think it was work that I was familiar with. It was making that decision about leaving the program. I think that was the big decision point.
So then can we ask what prompted that change?
Looking back at that time, just finishing treatment, actually my health was still really sort of in limbo, right? We would know chances of recurrence and things like that really up in the air. So it really, I think, when looking back, it really makes sense that, just wanted to take a back seat, in terms of work at that moment, and then kind of take things a bit easier.
So was that decision difficult to make, or it was quite clear by the time?
I think at that point it was certainly fairly clear. It was downstream later, then realizing, okay, with a different career track, there are trade-offs. Yes, and there are things to consider in terms of that. And I think then that came back later and kind of, again had a process of rationalization, acceptance, and
So I think that's something that you and I also, quite parallel. I also left training and became a resident physician. The path is different now, and you can't quite see clearly where that goes. And then there's also, you see your peers now.
Yes, absolutely.
Kind of
yes.
go off on a different track.
Yes.
That was difficult for me for a few
Yes.
years, I think. Yeah.
I definitely share those sentiments. I think what really helped me, especially early on, was joining a department that was really absolutely supportive. So I was not treated any different, even though I was the lone resident physician in the department. And then the opportunities, I think, gradually came. And again, also really appreciative for being in an organization that really, I think, recognizes competency. that has given me opportunities in many areas, right?
Did the team and the organization would have known your your story?
The team certainly, the team knew fully about the situation, but I've never spoken about it very openly. In fact, up until now, probably it's the first time I'm really talking in depth about this
Yeah.
in any big way.
How did all this that happened
Yeah.
bring you to patient experience and supporting staff?
Yeah.
Yeah.
It was not particularly intentional as well. I think by that time I was well settled into the department. So it's about 2018, thereabouts. And at that time, one of our senior colleagues, Dr. Daniel Quek, was the director for medical manpower. So he already in that role was looking after the junior doctors within the organization. And he was doing a lot of informal support, one-to-one on colleagues in need. And so I think that was an area he felt that he could bring me on to. It's true that started getting me to work with other stakeholders in the hospital, getting to know the nurses, security team, operations and all these things that was, I think, quite interesting. And I realized I started having a knack of reaching out to the other stakeholders in the hospital. Then later they got me to start doing a bit of patient safety work. So that was as a deputy patient safety officer, specifically looking at safety culture, right? And also in terms of a bit of blend with the well-being. That's why it kind of dovetails in a way, looking how people feel safe, second victim support, how do we implement our restorative just culture policy, training on human factors. And then in the capacity as a deputy patient safety officer, there was a seat on the steering committee for patient experience and culture.
Do you see that your past experiences prepared you for the work that you're doing?
Understanding experience comes from many angles. Like, we don't experience everything for ourselves. I think one thing I did take away from my treatment experience was actually medical treatment is really quite scary. Just really being able to put myself in the shoes of, I don't know, someone who doesn't have any healthcare training or exposure, how much more anxiety inducing the process must be.
And I actually frequently tell my patients, when they come and I say, how are you feeling today? And then I'm very nervous. And it's totally normal to be nervous. We do this every day, but for them, this is the one event of the week or the month or the year. What about supporting staff?
My perspective of supporting staff is slightly more of also an extension of my care for patients. So in the course of work, we look after patients who are in distress, right? And in that sense, realizing that you don't look, as healthcare workers, we also experience many of these emotions, distress and things like that, and are worthy of care, right? So as a system, when we are well placed to experience it ourselves and also have some degree of expertise to be able to care for others, why not?
Healthcare is very task oriented and outcome focused. And so we don't usually take time or feel that we have the time to indulge in these softer aspects because we don't see how they directly influence the outcome. But there is so much research and evidence and even anecdotal, right, in real life, how that little investment in the relationship between colleagues, especially in healthcare where there's no way that we don't work as a team, right? That's what is actually going to take you further.
In general, we are less emotive in that sense. And therefore, when we interact, sometimes it can be a bit cold, it can be a bit corporate. Going back a little bit to your episode on psychological safety, right, almost. But can we feel comfortable and safe to be ourselves and relate to one another as really people?
In the course of your work in supporting staff, have there been any incidents that have really stood out for you?
I think one that springs to mind and left quite a deep impression was when I was called to the ward after an incident where a young medical officer had received some abusive language from patients, caregivers, and so of course I was tasked to kind of speak with the junior doctor. I remember asking her which aspect of the encounter she found most that was most affecting her, and she said it was when the caregiver had accused me of not caring for the patient. So rather than the raised voices or the aggressive behavior, it was the accusation that I don't care. So I think that really was left a strong impression, because it is a demonstration of the level of commitment and that that investment that many of us, regardless of job family, I think as healthcare workers, we bring to the job, and it's something that I've seen bear true throughout many of the encounters I've had.
How then did you help her?
I think at the very fundamentals of it is actually really just validating, right? That level of commitment, that you did your best in terms of delivering the care. Clearly it somehow was lost in translation with the family or the patient, but that's a secondary issue. But at that moment is having someone else just see that yes, the intention is there, the efforts were there. I think hopefully gives a little bit of consolation in that moment. Yeah. And then downstream, how to manage, or how to then demonstrate, I think, our kindness and compassion with family members, that comes later.
Yes. I think that sounds like getting to the root of what was troubling her, and the fact that you were able to get that out, get to the root of it, and offer her that her belief that yes, she was there for the right reason. Sometimes it goes wrong, and it doesn't stop us from continuing to try to do, carry on and do the right thing, which is what resilience is. Darryl, what I'm hearing from you is you really see people as people, as it's just a common humanity. And whether you are playing the role of a patient or a staff member, every single person deserves that lens. There are so many ways to interpret challenges when they happen to us, whether we beat ourselves up about it, or whether we have, the grace, I guess, as people like to say nowadays, to take what comes and just, as you put it, put one foot in front of the other. That is really what resilience is, to keep going and not give up. You have shown us, if we just look at you, if we pass you in the corridor, there's no way that I would have guessed that this is the journey that you took. And I think that is the message that I want to remind myself and everyone watching, that this is the same. Is this true for anyone else that you're going to pass in the corridor today? And to have that curiosity for the person, because you never know what story you're going to hear that is so inspiring, is so relatable, makes you feel less alone.
Yeah, and I hope that the idea then is that actually really everyone does have those strengths. I think it's not a matter of whether there is a story, but there are aspects that are, worth discovering, worth exploring, worth strengthening in everyone.
Thank you so much, Darryl. So, we hope that after you've watched this episode, you're prompted to think about your colleague or, the next person you meet at work, and think about what's their story, maybe if they're having a bad day, to ask what's going on behind that, because you never know. Maybe showing that care might be what they need as well. I hope you've enjoyed our podcast. If you like the series, please continue to watch. We have lots of more upcoming episodes. And again, thank you so much for being with us today, Darryl.
You're welcome. It's a real pleasure.